Morning, students. Today, the topic for discussion is attention deficit hyperactivity disorder. In psychiatry, we have disorders even in children also. Common disorders are ADHD, that is attention deficit hyperactivity disorder, autism spectrum disorder, conduct disorder, opponent defiant disorder, elimination disorders. So, today we are going to deal about ADHD. So it is a neuropsychiatric condition affecting preschoolers, children, adolescents, and around the world, characterized by a pattern of diminished sustained attention and increased impulsivity and hyperactivity. So the key points are the attention will be decreased and the impulsivity or hyperactivity will be increased. Coming to the epidemiology of this ADHD, you can find more child cases in male childs, that is 5%. In children and adolescents, and 2.5% in adults. The rate of ADHD in parents and siblings of children with ADHD is 2 to 8 times greater than the general population. That shows it carries a genetic epidemiology. And when compared to boys is to girls ratio, it's comparatively high, 2:1 in boys, and it may even go up to 9:1. What is the cause? Why the children are having or developing ADHD? So these are the causes implicated: genetic factors, neurochemical factors, neurophysiological factors, neuroanatomical factors, developmental factors, psychological factors. We'll see one by one in coming slides. Genetic factors. Genes involved in dopamine regulation are highly implicated in the etiology of ADHD. That means dopamine transporter gene, which is also called as DAT1 gene, and 7 repeat of dopamine receptor gene, DRD4, implicated. These two genes are most commonly and has been proved in a lot of studies. There is the involvement of this two gene which is related to dopamine regulation. So there is a implication that dopamine is one of the major neurotransmitter which is implicated in the development of this ADHD. And also other neurotransmitters like norepinephrine, epinephrine levels are also found to be variable. Clots and colics found significantly elevated beta activity in ADHD children. In EEG of these children, beta activity was found to be very high. Coming to radio imaging studies, these showed the evidence of decreased volume and decreased activity in the following regions, like prefrontal region, which is responsible for the attention. So there is a decrease in attention. Anterior cingulate gyrus, globus pallidus, caudate, thalamus, cerebellum. All these regions were found to be either decreased in volume or decreased in activity in ADHD children. Coming to developmental factors, higher rates of ADHD seen in children with premature birth, maternal infection during pregnancy, perinatal insults to brain. September is the peak month of births of children with ADHD. It is related to this influenza virus like that. But other causes of developmental like premature birth, maternal infection during pregnancy, perinatal insults to brain have been well studied. Psychological factors like maltreatment of the child by the parents or the guardians, neglect of the child, temperament of the child, all these are responsible for development of ADHD. Moving to the clinical features. Most cited characteristics of children with ADHD are hyperactivity and attention deficit. So these two are the major symptoms, followed by impulsivity. Hyperactivity, the child will always be very hyper, running here and there, mm, running over the stairs, coming back. It will be very difficult for the caregivers or the parents or the guardians to take care of the child. He will be always hyperactive. Because of this hyperactivity, they may always sustain some injuries. On observation itself, we can see this hyperactivity. Then another clinical feature is attention deficit. We can see this attention deficit by short attention span. If you speak to the child, it will not hear for you even for a couple of minutes. It will move away from you and go to the next job. So they cannot pay attention to a particular for a sustained time and easily distractible. If they hear noise from somewhere, immediately they will go there. So normally the children will be like this, but when compared to the other children, they will be looking like odd man out. Like the high amount of distractibility is not there. Failure to finish task. If you ask them to or give some job, you have to complete with this news. Since they have increased distractibility and short attention span, they could not complete that task. Immediately they will go to another job without finishing this. Inattention, I said before, and poor concentration. Because of inattention, they cannot concentrate in anything. So most of the parents who bring their ADHD children, they say, so nowadays his scholastic performance is coming very low, or he is even failing in the subjects. These are the complaints will be set by the parents of the ADHD children. Then impulsivity, they will do immediately whatever they want to do. That is called impulse. They cannot control their impulse. Action before thought. Abrupt shifts in activity from one activity to another. Lack of organization. Jumping up in class. So in schools, teachers will be complaining frequently, especially in the parents-teacher meeting, or they will call the parents personally. They will be always complaining that your child is not sitting in the bench, he is jumping in the class, he is distracting other students. Like that, there will be a complaints by the teachers. And since prefrontal is responsible for the attention and there is lack of attention, the child has memory and thinking deficits, specific learning disabilities, even speech and hearing difficulties are also noted in ADHD children. What are the associated clinical features that can be noted in the ADHD children? There will be emotional ability. The child will be throwing temper tantrums. There will be ability of the mood. Will laugh, immediately to start crying, and it will be youth time. So there will be difficulty in assessing the child's mood because of this ability. Then school difficulties, both learning and behavior, commonly exist with ADHD. In ADHD children, they will be noted by the schools or the parents. There will be typical problem, especially in two aspects. One is in scholastic, that is learning, and also in behavioral aspects. These two will be the main concern for both the parents and also the teachers. So, according to ICD-10, how it is classifying ADHD? The cardinal features are impaired attention and overactivity. Both are necessary for the diagnosis and should be evident in more than one situation, either in home, classroom, or clinic. Some children, they will be smart enough. When they come to clinic, they will be sitting quiet. So that does not mean that we are ruling out the areas. Not like that. We have to ask the history both in the school and in the classroom so that you can correlate the history properly. So as ICD-10 says, there will be decreased attention and overactivity, which is called hyperactivity. These two are the cardinal features of ADHD. Impaired attention is manifested by prematurely breaking off from tasks and leaving activities unfinished. If you ask them to write some, say, for English homework, you'll write 2 words and go away to do some other work. And if you ask them to do write some Tamil homework, you will write 2 words and go away. So all the jobs he will touch, but he won't complete. No? That means the child is not having sustained attention. There is always some impaired attention or decreased attention so that it cannot continue to do same job, not even for half an hour. The children change frequently from one activity to another, seemingly losing interest in one task because they become diverted to another. Although laboratory studies do not generally show an unusual degree of sensory or perceptual distractibility. When you assess the child, there will be no sensory or perceptual distractibility, but the child's behavior will be so. These deficits in persistent and attention should be diagnosed only if they are excessive for the child's age and IQ. See, if you see some deficits or attention problem during the development, the 1 year child may know something, 2 year it may learn some extra things, third year may. So the deficit should not be incongruent to the age. For 1 year, if you expect too much of thing from a child, that is not possible. So the deficits in persistence and attention should be diagnosed only if they are excessive for the child's age and IQ. The child is say 5 years, it should develop proper attention. So 6 to 7 years, still more proper attention. Even after that, they are not having attention. Then it should be seen as a problem. Normally, after 5 years, all the child will be somewhat hyperactive. All playful activities. That is normal for the child. Next point is overactivity implies excessive restlessness, especially in situations requiring relative calm. Wherever you expect to be calm, there you can see this ADHD children should be very, very active. They will be restless. Everybody in that region will be seeing the child. So that is called overactivity. Where it is not required, there they will be. It may, depending upon the situation, involve the child running and jumping around, getting up from seat when he or she was supposed to remain seated, excessive talkativeness and noisiness, or fidgeting and wiggling. See, all these things the ADHD children will do. The standard for judgment should be that the activity is excessive in the context of what is expected in the situation and the comparison with other children at the same age and IQ. Say you are assessing a 6-year child Comparative, you have to, as a scale, you have to assess the another 6-year child, so that the child whom you are assessing is very, very abnormal from the same age group to the other child. This behavioral feature is most evident in structured, organized situations that require a high degree of behavior self-control. Say, where in schools, almost in 5th standard, all the age will be almost same. Maybe there may be 6 months, 1 year difference. Among those children, the ADHD children, they will be looking odd man out. They will be performing odd man out. Their activities, behavioral disturbances, attention problems will be odd man out. So that can be easily judged. So only most of the ADHD children are brought only after being joining in the school. The teacher will report his abnormality. A characteristic behavior problem should be of early onset and long duration. So before age of 6, you cannot diagnose ADHD because there will be normal playful activities of the child, hyperactivities of the child is not. So after age 6 years only, you can diagnose according to ICD-10. However, before the age of school entry, hyperactivity is difficult to recognize because of the wide normal variation. Only extreme levels should lead to a diagnosis in preschool children. Can you understand? That means before the age of school entry, hyperactivity is difficult to recognize because of the wide normal. As I mentioned before, all the children under this school age will be hyperactive. That should not be misdiagnosed as ADHD. Only extreme level of difference should be taken into consideration for ADHD. So, what are the scales used to assess ADHD? Honors rating scale. This is a commonly used rating scale for assessing the ADHD in children. That is actually a used as a screening tool for ADHD. There are teacher version, parent version, self-report version, and also short version, long versions of person. In short version, 10 items per person, whereas in long version, 80 items. You have to answer 80 questions. And the reliability and validity is really excellent for this bonus rating scale. So if at all you suspect a child as ADHD, you can use, for example, if you are a teacher, you can use teacher version. If you are a parent, you can use parent version. So all these things can be used. Coming to the differential diagnosis. Based on the hyperactivity and attention deficit, you can immediately jump into a diagnosis of ADHD. You also should think of other conditions which mimic like this. In mania also there will be hyperactivity in children. In conduct disorder, there will be hyperactivity along with attention deficit. They don't concentrate in studies. They just want to do other activities other than the studies. So their attention span is also very low. Hyperactive behavior is noted. And in specific learning disorders, the learning capability is less in particular subjects. So that should not be completed with ADHD attention deficit. Where it is a specific learning disorder with a separate diagnosis when compared to ADHD. And also in anxiety disorders, the child will be always having lack of concentration, anxiousness. So this should not be confused with ADHD. Course of ADHD is variable. Symptoms have been shown to persist into adolescence in 60 to 85% of cases and into adult life in approximately 60% of cases. That means if you take the life history of these ADHD children, whether it will improve or it will be static or it will worse, the answer of this question is 60, about 60 to 85% persist into adolescence and into adult life, approximately 60%. So the chances of persisting will be more. Remaining 40% of cases may remit at puberty or in early age. If you take 100 case, 60 it will persist, 40 either it will remit at the puberty or adulthood. And overactivity is the first symptom to remit and distractibility is last. So overactivity will first slowly it will reduce. And once it has improved, then attention deficit also improves. So this is the path or this is the direction how we treat ADHD. In long term, developmental outcomes for individuals with ADHD can include serious substance abuse, chronic criminality, depression, and suicide. So if you don't treat ADHD, if you live like that, what will be the long-term outcomes? They will become addicted to lot of substances, especially now during this period. You know how substance is common in children. So they can become prey to the substance abuse and they also indulge in criminal activities. Some persons may suffer from depression and some persons may even attempt to commit suicide. We have made the diagnostic criteria, clinical features, uh, what are the rating scales used for diagnosing this ADHD, all the things we have seen. Now you have diagnosed the case, it's your part to treat. What are the drugs available to treat ADHD? Actually, there are two forms of treatment. One is pharmacological, and the other one is non-pharmacological therapy. So in pharmacotherapy, stimulant medications and non-stimulant medications are used. And in non-pharmacological therapy, training is given to both students, teachers, and parents how to control this ADHD symptoms. These are the stimulant drugs which is used to treat ADHD. One is methylphenidate and amphetamine. This methylphenidate is not available in all the pharmacies. So you have to get separate license or it's available only in the government hospital setups. Because of its potential abuse pattern, the usage is restricted. It's followed by amphetamine. This is also used. So both methylphenidate and amphetamine are used as a stimulant to treat ADHD. Now you will see in detail about methylphenidate. It is a dopamine agonist. Methylphenidate targets the dopamine transmitter, which is DAT, which is implicated in ADHD etiology, and the noradrenergic transmitter, NAT, inhibiting dopamine and norepinephrine reuptake, and therefore increasing dopamine and norepinephrine levels in the synaptic brain. What this methylphenidate will do is that They will inhibit both dopamine and norepinephrine reuptake and thereby increasing their levels in the synaptic net. So what are the forms available? Methylphenidate forms. Short acting, sustained release, extended release, transdermal patch. Short acting interacts for 3 to 4 hours. Sustained release minimum for 8 hours. Extended release up to 4 hours. Transdermal patch up to 4 hours. The dose used for methylphenidate is 0.32 mg per kg TDS up to 60 milligrams per day can be given. Transdermal patch 30 mg per day can be used. Available preparations how dosage forms are 5 mg, 10 mg, 15 mg, 25 mg. But you have to calculate the dose as 0.3 to 1 mg per kg. Maximum of 60 milligrams per dose can be used for the adverse effects of this methylphenidate normally notice adverse effects are headache, stomachache, yeah, and insomnia. These are the commonly adverse effects. Headache, stomachache, and insomnia. And there is a rebound effect. If you stop the drug immediately after a few days, you will have the resurgence of the same symptoms for which you have started treatment. Long-term use of methylphenidate may cause growth suppression also. It's coming to amphetamine. It is also a stimulant drug. It is also a dopamine agonist. Mechanism of action is the stagger both DAT and the NET transporter, inhibiting dopamine and norepinephrine reuptake and thereby increasing the DA levels in the synaptic net. It's the same way as the methylphenidate. Thanks for short acting 3 to 4 hours, long acting low release 2 hours. Dose is 0.15 to 0.5 mg per kg, VD up to 40 mg per day. Normally, to keep in mind, you can have 0.5 mg per kg. Preparation of 5, 10, 15 mg. Dose of is same as before. Because of this abuse potential of these stimulant drugs, we usually prefer non-stimulant drugs for pharmacological treatment of this ADHD. What are the non-pharmacological or non-stimulant medications? So non-stimulant medications normally used for atomoxetine, clonidine, guanfacine, and bupropion. These are the commonly used non-stimulant drugs for treating ADHD. Atomoxetine, clonidine, guanfacine, and bupropion. Commonly used among these four is atomoxetine. So, in atomoxetine, it's available in the dose of 10 mg, 18 mg. So based on the needs, you can prescribe the dose. Clonidine is available 0.1, 0.2 mg like that. Based on this also, you can prefer your dose. Coming to non-pharmacological management of ADHD. So, as a psychiatrist, so we prescribe drugs ADHD cannot be cured only with drug. Non-pharmacological management plays a vital role. Say, out of 100% treatment success, 50% weightage goes to the pharmacological treatment, and 50% weightage goes to the non-pharmacological treatment. So, how you are going to treat non-pharmacological? What are the methods you are going to adopt? What we will see in this slide. This behavioral therapy, another is psychoeducation, another is exercise and diet. These three are the core symptoms, or sorry, core methods, non-pharmacological methods to treat ADHD. In behavioral therapy, what you are going to do? Parent-led behavioral interventions. The child might develop a lot of behavioral problems. The parents must be psychoeducated. If so and so behavioral problem is there, you have to inform, you have to stop the behavior by doing particular way. So that thing will be psychoeducated or counseled to the parents. In classroom-led behavioral interventions, where the teachers will be taught, or by our parents, the teachers will be known to follow certain class-led behavioral interventions to stop the ADHD symptoms in the children. And cognitive behavioral therapy directly to the patients. Patients who can sit and speak, even though they don't accept, slowly speak and make them as accept. The ADHD is a problem. You have to take treatment properly. And neurofeedback mechanisms, which helps in change of the bad behavior to good behavior. So, this behavior therapy, one is parent-led behavioral intervention, second is classroom-led behavioral intervention, third is cognitive behavioral therapy, direct to patients, and fourth is neurofeedback. With the help of the computer, you can change your feedback given by the computer, you can change your behavior slowly. So this behavioral therapy should be given more importance. Next, coming to psychoeducation. Educating patients, their families and children, sorry, teachers about ADHD, direct from clinicians at consultation, direct from clinician consultation, group education session. So all these part of psychoeducation that you should educate about the disorder to the patient, to the patient's parents, and also to the teachers. The teachers also should have training, should know about this ADHD symptoms for early notification, early treatment, that they all should be psychoeducated. Even group education sessions will create confidence in these ADHD children, followed by exercise and diet. Increasing physical activity, changes to diet, limited evidence. For example, there is increasing physical activity, and that might create changes or make changes in the neurotransmitter levels in the body, and that might have effect on the brain, thereby treating this ADHD non-pharmacologically. So increasing physical activity, changes to diet. Diet is, it should be a light diet, taking more amount of fruits, vegetables, which is good for your health. And once that is rejuvenated, it also rejuvenates your brain. Thereby, the ADHD symptoms can come down. As I mentioned, parent-led behavioral therapy aims to treat the core symptoms of ADHD and associated proportional non-compliant behavior. So, parent-led behavior out of this teacher, parent, parent-led behavioral therapy plays on the effects of this parent because most of the time the children are spending in their home. So that is the place where it should be behavioral change should be started. Classroom-based behavior therapy are delivered in real-world situations that provides training on the expected behavior within the context in which it is required. These interventions can be delivered by mainstream teachers following appropriate training in combined behavior modification and cognitive behavior modification techniques. So, classroom-led behavioral therapy also plays an important role in treatment of ADHD symptoms. Coming to CBT. CBT consists of self-instruction, training, administration on individual or group basis. So, what is going to do? It helps the patient to develop more planned and reflective approach to thinking and behaving, including social interactions. Adopt a more reflective, systemic, and goal-oriented approach to everyday tasks, activities, and problem solving, including academic function. Regular sessions of CBT have been shown to reduce ADHD symptoms in children, adolescents, and adults. So, cognitive behavior therapy is also one of the good option, a non-pharmacological treatment where we can see the response of a treatment within a month. And coming to exercise and diet, there is some evidence that physical exercise and diet interventions may be beneficial for individuals with ADHD. However, more research is needed in this area. We cannot completely reject this idea of exercise and diet having a role in ADHD, improvement of ADHD symptoms. Sometimes, some few studies have found that mere exercise and diet is reducing almost 20% of the ADHD symptoms, where it is also having a positive effect on the lifestyle of the particular children. So, what are the foods recommended? Omega-3 and omega-6 fatty acids in combination with supplementary magnesium and zinc should show the beneficial effects on attention, behavior, and emotion problems. So, this omega-3 fatty acids are found more commonly in seafoods. So, we advise for all the not only for ADHD patients, but also for most of the psychiatric cases. We advise them to take a lot of fish, omega-3 fatty acids. Dietary exclusion of artificial food colors had statistically significant effect on symptoms of ADHD. This unnecessary colors over the sweets, foods. If you eat these, the studies have proven that those artificial colors or foods can itself lead to ADHD symptoms in the children. So, even public or family or relatives kindly advise those children who are taking excess amount of artificial food colors should be not encouraged. So they have did a study. Those who have excluded these artificial food colors had a improvement of symptoms in ADHD. And micronutrient treatments is also very necessary. So combined treatment was superior. So I said first non-pharmacology, then pharmacology. In non-pharmacology, there are a lot of parent therapy, teacher therapy. But actually, who studies were done well, why are we doing everything in separate? For treating a single disorder, we can bring them in a single umbrella. So they brought combined treatment. Parent and teacher satisfaction of treatment is good. Normalization of child behavior is noted. Improvements in functional outcomes like family interactions, peer relationship, academic functioning is drastically improved. So they want to say the treatment was superior when it becomes combined treatment. Coming to your summary of our topic, attention deficit hyperactivity disorder is a highly prevalent brain-based disorder which is associated with lifelong impairment in functioning. Environmental factors can contribute to expression severity, course, and comorbid conditions. Long-term developmental outcomes for individuals with ADHD can include serious substance use, chronic criminality, and depression and suicide. Stimulant medications in behavioral therapy are currently used. The only established evidence-based treatment for ADHD. And combined behavioral pharmacological treatment has the greatest impact on functional outcomes, is preferred by parents and teachers, and is most likely to result in normalization of the behavior. Thank you, students.